All right, welcome. Today, we're going to dive deep into the biomechanics of one of the most challenging injuries we face, the Pauwels type 3 femoral neck fracture. This is one of those fractures that truly tests our understanding of biomechanics and really our choice of internal fixation.
So let's get right to the heart of the problem. What makes this fracture so tough? Well, as Pauwels defined it, the type 3 is all about that extreme verticality, an angle over 70 degrees. Now think about a more stable transverse fracture. When a patient puts weight on it, that axial load creates compression, right? And compression is our friend, it's great for healing. But with this fracture pattern, that same axial load, which can be 3 to 5 times body weight, gets converted into this dominant, destabilizing shear force that just wants to pull the fracture apart. So this naturally brings us to the critical question we all face in the operating room. Given these really hostile biomechanics, what's the best implant to counteract these forces? What's going to give us stable fixation and give our patients the best shot at avoiding devastating complications like non-union or avascular necrosis?
You see, these high shear forces create this powerful tendency for the fracture to collapse into varus, where the femoral head just angulates downward. This biomechanically hostile environment means any implant is predisposed to failure. And that leads to those unacceptably high rates of non-union, where the bone just doesn't heal, and avascular necrosis, the death of the femoral head, that have plagued this fracture pattern for decades.
All right, let's jump into the core of the evidence, starting with that classic debate in femoral neck fixation. Parallel cannulated screws versus the dynamic hip screw, the DHS.
We're looking at two completely different philosophies here, right? On one side, you've got the multi-point fixation of cannulated screws, usually in that inverted triangle pattern, trying to get rotational stability. On the other side, you have the load-sharing dynamic compression of the DHS, which really acts as a fixed-angle device to resist that shear.
Multiple studies using both cadaver models and computer analysis found the DHS to be the biomechanically superior construct.
And this chart, wow, it just lays it out crystal clear. In the cadaveric testing from Baitner and colleagues, the DHS construct withstood more than 3 times the load before it failed compared to the cannulated screws. That is a massive, clinically significant difference in performance.
But hold on, it's not a completely closed case against screws. You can make them better. The study by Hawks and colleagues showed that if you augment your parallel screw construct with a transverse screw that specifically targets the calcar, that really dense bone on the medial side, you can significantly improve its mechanical stiffness by up to 70%. This just hammers home that critical principle of getting direct medial cortical support to fight those shear forces.
Okay, so what about the heavy hitters? Let's talk about the more robust implants we often save for these tough fractures. Intramedullary nails and locking plates, both of which are fixed-angle devices.
Now, check out this number. The data for intramedullary nails is, well, it's pretty staggering. In a head-to-head test by Ruprecht, the intertan nail, which has that integrated rotational control, showed a load to failure that blew past even the robust DHS construct. This really points to its potential advantage when you need maximum stability. In the study, by Biomechanical, the proximal femoral locking plate, or PFLP, actually had the highest stiffness of all the constructs they tested. And, crucially, all of the plate specimens survived cyclic loading, which is something the DHS and cannulated screw groups couldn't do. It really emphasizes the value of absolute angular stability in this high shear environment.
Okay, so we've looked at a lot of data. How do we pull all this together into something we can actually use? Let's synthesize these key biomechanical advantages and see what they mean for our surgical decision-making.
This table really brings it all together. Cannulated screws alone, they just seem biomechanically insufficient for this fracture. The DHS provides a solid, reliable baseline and is clearly better than screws. And then you have the fixed-angle devices, the IM nails and locking plates, which offer the greatest stiffness and load to failure. This suggests their primary role is in those really tough cases, with posterior comminution, poor bone quality, or when you just need absolute stability.
All right, let's bring this home. How do we take all this evidence and actually apply it when we're choosing an implant in the operating room? So the real take-home message is this. The biomechanical data strongly steers us away from using cannulated screws by themselves. It pushes us toward more robust, angle-stable constructs like a DHS, a nail, or a locking plate. But that final decision, it has to be tailored to the individual patient, their bone quality, and the specific fracture pattern. And most importantly, no implant in the world can make up for a bad reduction.
And that's really the question I want to leave you with.
Knowing this evidence, this clear hierarchy of stability from screws to DHS to nails and plates, how does that inform your surgical algorithm for this incredibly difficult clinical problem?